Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So whenever you encounter USMLE style question, you need to read the last line first. Now this will give you an idea about what to look for in the long question stem and what information you need to catch up in the long question stem. So here we have which of the following is the most likely diagnosis in this patient and what is the primary pathophysiological mechanism underlying his symptoms and physical findings. So now we know that the question is asking us about the diagnosis and the pathophysiology behind the diagnosis. So we have a 72-year-old male who present to the cardiology clinic with complaints of progressively worsening chest pain on exertion, shortness of breath, and fatigue. He has a history of hypertension and has been a smoker for the past 40 years. On physical examination, you note a systolic ejection murmur, heart-based at the right upper sternal border, radiating to the carotids. A delayed carotid upstroke and a sustained apical impulse are also appreciated. An echocardiogram reveals thickening and calcification of the aortic valve with restricted deflate motion. Which of the following is the most likely diagnosis in this patient, and what is the pathophysiological mechanism behind this? So we have options: mitral regurgitation, increased preload; aortic stenosis, increased afterload; atrial fibrillation, decreased contractility; pulmonary stenosis, increased preload; and tricuspid regurgitation and decreased afterload. We will come back to this question, but let's dive into a little bit of theory about the valve and the valvular disorders here. So in this picture, I do not want you to go deep into the valvular anatomy of the heart, but what I do want you to know is that the tricuspid valve, okay, the right. So the right-sided tricuspid valve has three leaflets, and the left-sided mitral valve have two leaflets. And another thing is that we have the aortic valve, okay, which separates the aorta and the left ventricle. And this aortic valve has three cusps, okay. And now these three cusps, so two of the cusps have the opening for the coronary artery, the right and the left coronary artery. And again, then we have the pulmonary valve, which again have the three cusps. So whenever there is a defect in any of these four valves, it may lead to conditions, maybe stenosis or regurgitation. Two conditions. If the valve becomes stiff, then it leads to stenosis. If the valve becomes flexible, then it leads to regurgitation. So most commonly, so if you if you cannot just get to the answer to the causes of the valve disorders in your USMLE question, yeah, if you are left with nothing, then you can just remember this rule of the thumb. If the condition is age related, then it may be affecting the aortic valve. If the condition is infection related, then it may be affecting the mitral valve. If the condition is traumatic, for example, if the patient has undergone some procedure, so, due to which the catheter has to be passed from the right atrium to through the right ventricle towards the pulmonary artery, then there can be a traumatic injury to the tricuspid valve leading to tricuspid regurgitation. And if there is any developmental valve condition, then most commonly it is pulmonary valve. So this is not hard and fast. This does not apply everywhere. But if you are left with no option, then you can just remember this one, and then you can just proceed with your last option that you have. That is just remember this rule of the thumb and just approach the answer in the question. So let's talk a little bit about the different valvular disorders according to what your first aid says. So first of all, we have the aortic stenosis, okay? So aortic stenosis, the most common condition, the most common cause of aortic stenosis is age-related calcification of the aortic valve, okay? Now, due to the age-related calcification of the aortic valve, more pressure is needed by the left ventricle to pump the same amount of blood or to pump the blood from the left ventricle towards the aorta. So here you can see the black dot denotes the initial or the normal pressure volume loop, and this the red line denotes the aortic stenosis. Here you can see that to pump the blood or for the aortic valve to open, a bigger amount of pressure, a higher pressure, a higher left ventricular pressure is required to open the aortic valve. right? And the pressure is not so enough that all blood could be pumped out from the left ventricle towards the aorta. So the systolic ejection phase becomes smaller, okay, and due to which the stroke volume is decreased. And you can also see in this diagram that the left ventricle pressure is way more than the aortic pressure. It should only be slightly more than the aortic pressure to open the aortic valve, and there should be a prolonged ejection phase than the aortic stenosis, but that is not happening here. It is because the aortic valve is stenosed, more pressure is required to open that aortic valve. Here you can see in the second, that is the aortic regurgitation. That is, here you can see there is no true isovolumetric relaxation phase. It is because in the aortic regurgitation during the diastolic phase, during the isovolumetric relaxation phase, no blood should flow from the aorta towards the left ventricle. But due to the aortic regurgitation, more and more blood, or you can see there is continuous leakage of blood from the aorta towards the left ventricle, even in the diastolic phase. That should not happen. But due to the aortic regurgitation, the blood flows from the aorta towards the left ventricle, due to which the diastolic pressure becomes way less than the original, and that will lead to increase in the pulse pressure. The pulse pressure equals to systolic blood pressure minus diastolic blood pressure. And due to the large decrease or large drop in the diastolic blood pressure, the pulse pressure increases, and there is bounding pulse. There is uh, high pulse, high radiating pulse in case of aortic regurgitation. Here we can see, now coming towards the mitral valve, here you can see that in the mitral valve stenosis, due to the mitral valve stenosis, the blood cannot fully flow from the left atrium towards the left ventricle, due to which the preload of the heart, or the left ventricle volume just before the contraction begins, is actually lesser than the original. Everything else is okay. The aortic valve is okay. The blood is flowing from here, from the left ventricle towards the aorta. But due to the less amount of blood initially present before the contraction, the overall stroke volume just decreases, and the left atrium becomes way more, the left atrial pressure becomes way more than the left ventricular pressure, because the mitral valve is stenosed, the blood is accumulating, the lung is pushing blood towards the right, towards the left atrium, and the blood cannot pass from the left atrium towards the left ventricle, so the left atrial pressure just increases. And when the left atrial pressure increases, the patient will be having lung symptoms. Okay. Now also realize that whenever the left ventricle pressure increases, that pressure will ultimately transmit it towards the left atrium too. Now, in that case, for example, in case of aortic stenosis, the left ventricle pressure will increase because of the increased afterload. The blood cannot pass fully from the left ventricle towards the aorta. So the increased afterload is there in the left ventricle, and there will be increased pressure in the left ventricle, and then this pressure will ultimately be transferred towards the left atrium, leading to the lung symptoms too. Also, in isolated mitral stenosis, there will be also lung symptoms because of the isolated increase in the left atrial pressure. Understood. Now, talking about mitral regurgitation, again, in the mitral regurgitation, there is no true isovolumetric contraction phase, okay? Because in the isovolumetric contraction phase, the two valves, the mitral and aortic valves, which is there in the left ventricle, needs to be closed. But since there is continuous leakage of the blood from the left ventricle towards the left atrium due to the mitral regurgitation, there is no true isovolumetric contraction phase. And that's what your first aid talks about. And this information is very, very high here. Now, talking about the aortic stenosis and the mitral valve disorders, the murmurs, how these murmurs actually present in the patient. So the aortic stenosis murmur is usually a crescendo decrescendo murmur. Now, what do you mean by a crescendo decrescendo murmur? Is that the intensity just increases and then this just falls down. Now, this phase is called as crescendo phase, and this phase is called as the decrescendo phase, right? Now, it is because initially, because of the left ventricle pressure that is increasing the blood flow towards the stenosis valve, which increases the sound of the murmur, leading to the crescendo phase, and ultimately due to the exhaustion of the pressure, that is the decrease in the sound, that is called as the decrescendo phase. So remember crescendo, decrescendo sort of murmur. Then we have mitral or tricuspid regurgitation murmur. Now, these murmur are the holosystolic, high-pitched, blowing set of the murmur. It is because in the case of systole, the blood is continuously passing from the left ventricle towards the left atrium, okay? Towards the left atrium. Maybe, or it can also pass from the right ventricle towards the right ventricle, right ventricle towards the right atrium in case of tricuspid regurgitation. So there is continuous flow of blood in the systolic phase from the ventricle towards the atrium, and that will lead to the holosystolic high-pitched blowing murmur. Also, here you can see that in case of aortic regurgitation, okay. Now, in case of aortic regurgitation, there is the early diastolic, decrescendo, high-pitched blowing murmur based hardly at the base of the aortic root dilatation. Now, it is because that just when the heart goes into the diastolic phase, then from the aorta towards the left ventricle, there is flow of the blood from the aorta towards the left ventricle, which produces the early diastolic murmur. Early diastolic murmur, which is decreasing. That is, the intensity just decreases. In case of aortic stenosis, intensity increases and then decreases. But in case of aortic regurgitation, the intensity is only decreasing, and decreasing. Now, in case of mitral stenosis, there is an opening snap before the murmur actually appears. Now, it is because when the mitral valve is narrowed, now, to open this mitral valve, there is increased left atrial pressure. And when this stiff mitral valve actually opens, then there occurs an opening snap. Now, this opening snap also determines the severity of the mitral stenosis. If the opening snap is higher, then the mitral stenosis is severe, because it means that the more pressure is required to open that stiff mitral valve. Now, this is the very basic idea that you need to know about the murmurs and their mechanisms and how they actually appear, why they appear, what is the characteristic of the murmurs. Very high yield. Now let's uh, talk about some of the auscultation point of the murmurs. Now the aortic valve auscultation point is in the right second intercostal space. The pulmonary valve auscultation point is on the left second intercostal space. The tricuspid valve is just lateral to the left sternal border, and the mitral valve is also just lateral, is at the apex beat area. But if the mitral valve is the mitral murmur, the mitral defect is so loud, it can also be heard sometimes at the sternal border, right? Or in case of pediatric population, it will be already heard even at a minimal level at the left sternal border. Now, the correct answer to that question was aortic stenosis or increased afterload, as you all know by now. Now, the clinical presentation described including chest pain on exertion, shortness of breath, fatigue, a systolic ejection murmur at the right upper sternal border, delayed carotid upstroke, and sustained apical impulse is highly suggestive of aortic stenosis. Now, aortic stenosis is characterized by the narrowing of the aortic valve, which increases the afterload, and the left ventricle must overcome during systole. Now, this increased afterload leads to the left ventricular hypertrophy and reduced stroke volume, resulting in the patient's symptoms and physical findings. Thank you everyone for your concentration. We will meet again in the next video with our next super duper concept. Till then, keep studying hard. Thank you for watching.